morning, everyone.
No,
Nope.
It's not working. It's working?
It will. I think we need to start talking, and then it will work.
Okay. Good morning, everyone. We are going to start, so please take a seat, everybody. We wait 30 seconds, and we begin, because we are in a very tough schedule. Where we go? Yeah. Okay. Good morning. So this is the third plenary of this wonderful conference, and we are going to talk about health system performance assessment. We have been talking all around the conference about the COVID-19 pandemic, the impact that this has had, the resilience of the health systems, or the lack of the resilience of the health system. And in order, if we want to measure if a system has responded or not, we need to check, we need to study how the systems perform. So this is what we are going to talk now. In a way, we are building in the plenary 2 of yesterday that was about the European health data space. So we are going to talk about data, about information. But what we are going to present with these 4 speakers that we have today is how we check what the health systems are doing, how we check how they are performing for bad and for good, and as the title says, the uses and the abuses of the health system performance assessment. So there are many different areas that we need to check. We need to check if the systems are providing access, are providing quality, the populations are happy with the system, if it's responsive, if it's efficient. So a series of different variables that are going to build what is the measure for evaluating the performance of the health system. I don't want to enter in many different things. Just I don't think that we need to introduce the keynote speaker because it's Reinhard. Again, he has already performed himself in this conference several times, and he is going to give the introduction, and then we will pass to our panel. So Reinhard, and by the way, here moderating is me, Isabel de la Mata. I was yesterday in the second plenary, and Dimitra Panteli from the European Observatory of Health Systems and Policies. So Reinhard, go ahead, please.
Yes, good morning again, everybody. May I have the slides, please? Yes, I'm talking about, this is the introduction about health system performance assessment for policy, because this is what it is about. It's not a scientific exercise in itself, but we want to use it for policy, and we want to discuss uses and abuses. And you see 2 reports here, the one with which it all started in the year 2000, the World Health Report, Health Systems Improving in Performance, and a very recent document by the European Observatory on Health Systems and Policies. The first question is, and Isabel has already touched upon, why health system performance assessment? Well, I think the answer is relatively obvious. Health policy making and reforms of the health system require, first and foremost, a sound understanding of how a health system is performing. So how well is it doing? Where are the weaknesses in regarding to what we expect? And that means that we need an agreement about the objectives. So what are the objectives a health system should be performing, and what are the inputs or the elements which we have to look at and which contribute then to achieving the objectives or the goals of the health system. In the World Health Report 2000, with which it all started, they were called the functions. And at that time they were described, and I realize this is a bit small here. Oops, this is a bit small, as stewardship, creating resources, financing, and then foremost delivering services. And the objectives were the ultimate objective, health, and fairness in financing and responsiveness, also objectives. Many people at that time disagreed. If we are honest, go back there was many people were saying, yeah, you cannot do this. Where are the data? Some in principle, some on more details. And one of the details which was added was people were saying, yeah, but there are important dimensions missing from this framework. There are things like access, coverage, quality, safety are missing. So that a revised framework which shaped our thinking in the next years then said, okay, we have the functions or the building blocks, as it was called at that time. We have the overall goals, and then we have intermediate goals, and they should contribute to achieving the overall outcomes. And one of the overall outcomes, which was already there in the 2000 report, but not explicitly mentioned, was the efficiency. So you see now a fourth ultimate goal. You can then further develop this and make things complicated, and clearly it's, on the one hand, it's totally understandable that we add dimensions, that we say they are cross-sectional. When we can not only look at quality, we have to look at effectiveness of effectiveness. Sorry. On effectiveness, on safety, on user experience, but then what about the equity elements, the efficiency elements? So these frameworks can get more and more complicated, which shows health systems are complicated, but also which makes it less obvious how to evaluate. And even others say the world of health system looks differently. So you cannot present it in a monocausal way from inputs to outcomes, but all things are interrelated. And clearly that is an important consideration. How do we frame health systems in order to present data which are useful for policymakers? I'm a friend still of a very easy way forward, and say we need to present it in an easy way. This is from our own German HSPA pilot. So we have the health system with the good old building blocks, governance, financing, creating resources, and providing health services. And then we need to look at the outcomes. And we have accessibility, and those people who make it, we discussed it yesterday in Plenary 1, with the universal health coverage, those people who make it to health services, then it's important that they get high quality services to produce as much population health, but also to measure the responsiveness of the health system to people's expectations. But it's clearly, we need to make sure, in order to avoid abuses and make the exercise useful for policymakers, that the indicators which we use to measure whether the health system is doing a good job, whether they are valid, and the underlying data are valid, and clearly, because we want to, as I said, we want to design our health system better. So when we measure the outcomes and we see deficits there, then we need to go back and say, okay, which of the elements on the left-hand side we really need to change. I have an example here also from the German report. This is on the unmet needs. You have already heard yesterday also about the unmet needs. And we see it was quite good in Germany all along, in the range of about 2%, similar to what we saw yesterday. And then there was a sudden decline from 2015 to about 0.5%. And so when you present this, people would think some great reform must have happened. When you go into details, you see that the question in the underlying questionnaire was changed, at least in the German version. And so it's not a real change, it's just a change due to the measurement. I have two examples here of what also might be useful, and that is difficult to grasp. It is the equity component. And this is from a special report here from our friends from Belgium, from the Belgian Knowledge Center, when they looked into the equity component, and they disentangled the population by income group here at risk for poverty up to the upper middle class, but also some other special groups here. These are people with severe mental deprivation, for example. And then they looked at various utilization issues, GP consultation, specialist consultation, emergency department visits, and hospital admissions. They linked them with individual data to really see whether utilization is higher than average or lower than average, adjusted for their needs, and then they present it in this way. And then when you can use that then to easily see whether things, these are 3 data points here, whether things are improving or not. So we have visualizations which help policymakers to understand whether they are on the good way or on the bad way. And in Belgium here, we see that for specialist consultation, we see more inequity, while for emergency department visits, for example, we see more equity, and for specialist consultation, less equity. Last example, and this is on the efficiency domain. I take this from the German report here, and we present cross-sectionally data. On the y-axis, we have the avoidable mortality, so that part of mortality which can be attributed to a good health system. And a good health system should lower this attributable mortality, and on the x-axis we see expenditure. So we see efficiency over time, and when we take 2 examples here, Germany and Denmark had a similar starting point in regard to costs per avoided mortality, and then they develop very differently. And this is an important consideration. You cannot take it automatically to then say, why was Denmark better? So the mortality was falling much quicker in Denmark for less additional expenditure than in Germany, but then you have a good database to then to go into details and say, okay, what was it about that one country did differently than the other one? The HSPA itself will not tell you, but it's a good database to then discuss with policymakers and see how things should be developing. So this was a very, very short introduction with some highlights, some spotlights on health system performance assessment. And with that, these will be the questions which we will be debating here, Dimitra and Isabel, in the panel. You can read them, they will be repeated, but obviously you should also be able to ask your question, and that's why we have a Slido set up where you can put in your questions. Thank you.
Thank you very much, Reinhard, clarifying that the Slido is an open Q&A. So there is no specific question for you. This is your platform to actually put in your comments or your questions for the panel. And we will later on in the session hear a summary of them and feed them back to the panel. In the interest of time, it's the best way we can think to organize your inputs for us. Thank you very much for the keynote, Reinhard. I think clearly highlighting both the components of performance that we need to think about and also some practical examples. We have 3 excellent panelists with us who will reflect on Reinhard's keynote and the main question about how we can use HSPA for policy, linking it to their own work. And we start with Kenneth Grech from the Ministry of Health of Malta, but Kenneth is not only, has not only his Maltese hat on, he's also the chair of the European Commission's expert group on health systems performance assessment, and he will reflect based on those capacities. Thank you, Kenneth. Over to you.
Thank you, Dimitra. Yes, as the expert group, we've been in place for the last 8 years or so, and since the very start, we've been grappling with this issue, how to make HSPA relevant for policymakers. And in fact, in all the reports we've produced up to now, so whatever subject, so whether it was efficiency, about access, about quality of care, at the end of each report, we always had a section on its impact, its relevance, on policy making, because we understood that that is really the final objective of HSPA. And if we don't really reach that objective, it really falls short of the whole process, really. And so I think we also need to understand HSPA, whilst it's a very highly technical subject in terms of actually building your framework, your model, your indicators, collecting your data, people also have to understand it's a highly political process, because it has an impact on policy, it has an impact on policymakers, on the political landscape of the country where you're measuring your health system performance. And so we, as an expert group also, we advocated a lot for open communication, so for transparency, and for communicating the results, really, of whatever processes that HSPA come up with. And in fact, I think from our experience, we have obviously the advantage of having all member states on the expert group. And we can see all the different aspects, all the different experiences. And different countries use HSPA for different reasons. So probably countries like Belgium, the Netherlands, Sweden perhaps, where they have a long tradition of HSPA, they really incorporated that process into the policymaking framework. Other countries, such as Italy, use it much more for performance assessment and for funding purposes. Other countries, such as Ireland and my own country, Malta, we linked it very closely to the reform process that we're undergoing at the time. And then other countries, I mean, Reinhard obviously would talk about the German experience, the Austrian. They're very wary, they're very much aware, if you like, that it has an impact on the political determinants. So they really treat it almost like with kids' gloves, if you like. So there are all these different aspects, but certainly the key is how to link it to policy. That's really important.
Thank you very much, Kenneth. And just to make clear also for the audience, all the reports of the European Union's expert panel are available to the public?
They're all on the website. Yes, they're all available.
Thank you very much. We come back to that and also communicating to decision makers, but also communicating to the public perhaps later on in the session. We now move to our next panelist. Irene Papanicolas is a professor of health services policy and practice at Brown University in the States. Irene, you've been working on HSPA for a long time, so bring us your perspective.
Great, thank you. It's a pleasure to be here and comment on the presentation and part of the panel. I wanted to start just reiterating, I think, a point that Reinhard made very clear, which is that the objective of HSPA is to identify where the health system can improve and, importantly, how it can improve in these areas. But this is also the challenge of HSPA. Creating a simple way to think about the key outcomes and the key functions of the health system, while also presenting the complexity of the health system, and that it's not just the health system that affects outcomes, but the broader socioeconomic political landscape. So how do you do this in a way that's simple and measurable, while also being very aware that there's many factors that we need to consider when we interpret the findings that we see? And I think this is the challenge, and this is where many abuses of HSPA can arise. When we struggle with this latter part of identifying how to improve or identify the reasons for the variation in outcomes that we observe, either kind of within systems at the organizational level or across systems if we're looking at comparative outcomes. Too often, HSPA efforts can stop there and just say, here's variation in outcomes without sufficient explanation maybe of why these exist or where to look further to identify all of the factors that we need to consider, such as the different measurement that might be occurring, the different health system factors that might be related to this variation, or the different external factors. And this is where I think there's a lot of important work that's happening and that's being discussed, I think, on the panel too, and that we've been involved in, that tries to think through this latter part, to think through much more, how do we also think about the functions that the health system performs and how well the health system performs these functions and how that in turn is linked to the outcomes the health system produces. And so we've tried to think this through in the framework for HSPA for UHC. And really what we're doing is trying to bring together this idea, I think, that we all support, that what happens in the health system and how these functions are carried out can influence outcomes. And therefore, we need to think not only about measuring the outcomes of the health system and looking at the variation that occurs there, but also to measure the performance of the functions. So how well is financing set up in terms of its revenue raising, for example, of its purchasing? How well does resource generation perform, or what are the variations across countries, for example, that might drive differences that we see in intermediate outcomes or final outcomes? And think also about measures that can show us variation in this part of the health system that can help us understand where to look for these improvements or where to look to explain some of these variations. Of course, keeping in mind also differences in measurement that were pointed out, differences in politics and the broader landscape. I believe that this approach can help us address some of the common abuses of HSPA, kind of this maybe looking at outcomes too simply or stopping there or misattributing and drawing too quick conclusions about the variation that might occur across providers or across countries. The way that I think about HSPA is more that it can be a tool to help find the right questions rather than necessarily find the definitive answers. And that by using HSPA and by thinking through these different actions that the health system performs, how we can look at the variation across entities, we can rule out some things that aren't the cause of variation in outcomes and find the areas that we need to focus on in much more detail to identify how we can improve them to affect outcomes. And that's what I think a lot of the work that we've been doing with the framework tries to help policymakers with, to identify how to do this and what to look into for more detail.
Thank you very much, Irene. And I think we get back to this idea of attributing specific effects to specific parameters later on in the discussion and how we can abuse that mostly, I think. Last but not least on our panel is Marina Karanikolos. She is one of my colleagues at the European Observatory, based in our London hub. She's a research fellow there and also has been working a long time with HSPA and health data in general. So Marina, over to you.
Thank you very much, Dimi, and thank you for inviting me to be a part of this great panel. As Reinhard looked at the evolution of HSPA and the differences that emerged, I would like to focus more on similarities. And what we have done in the HSPA book is reviewing the existing HSPA tools and frameworks. And when you look at them, they actually have a lot in common. And the health system elements may be called functions or building blocks or control knobs. And there may be some level of disagreement in the terminology, for example, governance versus stewardship. And sometimes we have pharmaceuticals or information sitting in separate domains. But overall, we agree on lots of the components, and there's always a set of objectives as well, or goals, which are mostly about things like health improvement, enhancing responsiveness or health system efficiency. And visually also, we can see that this can be represented in very different ways, in very different shapes. And the placement of things within the health system can vary. And we had months and months of arguments about where to put certain things. And they can have certain starting point as well. So for example, whether we start from the health system side or at a completely different end at the outcome side, but still there's a good degree of agreement on the actual content of HSPA frameworks. And how actual assessment can be done can also vary, but again, the review that we've done, we've seen variations which are often legitimate, or they're done for legitimate reasons. So for example, some of the approaches would purposefully use functions because they highlight the dynamic element of the health system and they want to stress the processes. This is what health systems do. And for others, building blocks are more appropriate because they often correspond to health system structures or the ministry structures where there is a separate department, for example, for pharmaceuticals or for information or digitalization. And the purpose of HSPA framework for UHC was to find the common ground in all of the spectrum of the various tools and enable countries to use information that they are collecting or have already collected to bring the performance part of it and the linkages between the health system components and the goals to bring it to the forefront. And in practice, when countries develop their own HSPA approach, they still tend to use a lot of the same concepts, but then they tweak the components to better correspond with their own health system design and structures and priorities. For example, in Belgium, a country that has one of the longest running systematic HSPA. It adjusted their framework more than 3 times since 2010, and now they're in the process of another revision. And why? Because over time there appeared to be the need to be more specific about certain areas. For example, like quality needed to be disaggregated into effectiveness, appropriateness, safety, and so on. And then there's always a need, there was a need also to assess separately services such as mental health or long-term care or health promotion. These are areas that are often neglected, so that these services were added and named more specifically. And then with COVID, we see that, and with other shocks, assessing governance and resilience and sustainability became more important. And I think any approach to assessing health systems performance needs to be able to adapt to this country context.
Thank you very much, all of you. So we have learned that countries could use health system performance assessment to communicate, to fund, to inform reforms, to justify reforms, and at the same time, Reinhard presented how small changes in questions can completely shift the results. Timing in the questions or in the survey can completely shift the result. So taking into account all that, now we will go to the different questions that we have prepared for the panel. The first one is for Irene. How can you interpret the outcomes of the health system performance assessment to determine what requires change and reform?
So, yeah, I think this goes back to some of the points that I was making initially. And I think it's very important here when we see variations in outcomes to take kind of a step back before we jump to any conclusion about what this means for performance. And I mean, I think as has come out from all of the initial points from the reactions to the presentation in the panel, there's a number of factors that can be different. If we're looking even within a country, but especially across countries, there might be measurement differences. And it's really important to consider that as a starting point. You know, are we measuring things the same way across the entities that we're comparing? And could that be a source of variation? This could be differences in the severity of the populations that we're looking at. It could be differences in the structures that we're looking at. You know, if we take an example like length of stay, which is often compared both within and across countries, you might have differences in length of stay because of the population that you're looking at. You might have it because maybe you measure the start point and the end point at different times. You know, in some hospitals, rehab care might be included for certain conditions, and in some hospitals you could be discharged in the community for rehab care. That will influence your length of stay, and it doesn't necessarily mean that one system is more efficient than another, for example. So we need to think about measurement differences. We need to think about underlying populations. We also need to think about what are, you know, structural differences that might explain it, or factors that we can improve, you know. And so maybe there are inefficiencies, and thinking back to how do we set up the groups of patients that we're treating together? Where do we treat them? Thinking back to the functions, how do we pay for care? All of these different elements that the health system performs, and can we look at how those factors, first of all, might influence variations in outcomes that we're looking at, and think about how they can influence them. And then we can create sort of a list of things to look at and slowly rule out things that we don't believe are related to the difference in outcomes, and really focus our investigation on the areas that we do see differences across organizations, either in the way things are set up, in the populations that they treat, you know, in the areas that they are. There might be a reform that's happened, but there we can zoom in and start to really do the analysis or ask the right questions. And I think that's what's really important to take away from this, is that HSPA can be a great tool to identify what the right questions are and where to focus. They don't necessarily always tell you definitively what is the only area for improvement or what is the direct causal link, but they do help you focus on what are the areas that you should look into.
Reinhard, maybe you could give us more information about the recent experience with the HSPA in Germany.
Well, I mean, the first thing is we are all assuming that everybody wants to have health system performance assessment to improve. I think then that's an important prerequisite, is that you have policymakers who are eager to to learn. And if this is not the case, and in our countries it's sometimes difficult. Policymakers say we have, depending on the policymaker, we have the best health system or we have one of the best health systems. And if you start from that point, you know, you're not eager to do health system performance assessment because it could prove you wrong. So why embark on this? So this is what explains why we are relatively latecomers in this process, if we are honest, and also why we still have debates with the ministry. We as the writers, the data analysts of these reports with the ministry, whether to make this public or whether it's for them to put in their drawer and use as a secret source of information. Then we had all the debates, what Irene just said. I mean that, you know, the attributability, and people will say, yeah, but in France everything is totally different. You cannot simply compare France with Germany. And if you only have cross-sectional data, so across various countries for one point in time, people will say, you know, the attributability is an issue and we cannot make much sense of it. So that's why we said to make it more, that our policymakers believe it more, that we say we need to produce data longitudinally. Because then if you see changes, let's say in France and in Germany with their own data points, then yes, we assume that there are certain underlying issues which might be different. But then if trends go different way, this was my example with Germany and Denmark, then there must be something going on. And so early on, the people who commissioned us in the ministry said, if lines, for example, cross, so if one country is crossing the line of another country, then we know, depending on which direction, whether we are on the right track or whether it's going in the wrong direction. So I think we really need to think, how can we make this really visible, very bluntly visible, that it is accepted by policymakers, while hidden small changes, it's difficult to grasp their attention.
Yeah. I remember when the World Health Report 2000 was published, the countries that were at the top, they said they were very happy and said, I already told you we were the best, but, you know, and this report was not necessary. And the countries that were in the bottom, they said, this is wrong, the report is very bad, and we are not so bad. But, I mean, we had a discussion, that was the important thing, in the general newspaper, that at the end, this is also something that is important, that we go out of our usual suspect channels of communication, and that this is a debate that is taking place outside of the or not only in the ministries of health, not only in the healthcare specialists, but outside. Any of the other members of the panel? Kenneth, Marina, do you want to get it?
Perhaps. Also, I think we have to reflect on the effect COVID has had also on the HSPA process, in the sense that I think during COVID, even now, post-COVID, well, I'm not sure if we should use that term, but anyway, after the acute phase, HSPA has really been brought into the forefront, especially to measure, you know, search capacity, HR issues, workforce, non-communicable disease issues. Now that's obviously we're seeing mental health. And in fact, we have been asked the question, is HSPA useful to measure all these different aspects, especially, for example, mental health? And the real answer is no, because we haven't really measured mental health as part of the HSPA process. So we're looking into you know, measures and tools to be able to do that. And also, I think for the first time we're seeing, sort of not just at the national level, but even perhaps at the European level, where HSPA could be used possibly to measure performance, you know, at a regional level, so to say. So, for example, you know, the EU Recovery and Resilience Plan, where, again, we've been approached saying, listen, can we use HSPA for this purpose in order to be able to measure whether this plan is being implemented effectively or not? And I think this is obviously the result of COVID and the need to have real data, obviously in real time and accurately, and data which is relevant for policymakers. So the link with policy has really been highlighted in this sense.
Thank you. Nicole, how is going the Slido? Up on the, or down? No, not necessary. So
Up.
we have quite enough traffic. Okay, good. That's good.
That's excellent. Kenneth, you just mentioned the potential of a regional HSPA. We've heard quite a bit about the difficulty of actually comparing between countries in terms of limitations of comparability of data. So perhaps we can reflect a bit on how we can effectively look. This is one of the main ways that we can know when our health system perhaps is not going in the right direction. We see what everyone else is doing. But how can we do that effectively if we have all these limitations? Kenneth, perhaps we start with you since you...
Yes, again, it's something that we've looked into over the years. And I think from our experience, it's really, first of all, it's about sharing the results or the outcomes, and also the process. And having countries discuss, debate, not necessarily compare for benchmarking purposes, but certainly looking at good practice and good practice outcomes. So that's something that we do continuously, and it's something that enriches the whole process, if you'd like. Also, I think we've looked at, we've asked ourselves the question: do we need to standardize the methodology for HSPA across all the different countries? Because in a way, there has been sort of, again, over the last decade, sort of a convergence of methodology in terms of generating the domains or the functions or dimensions, looking at your indicators. Most of the domains are very similar. If you look at the different frameworks, different models, most of the indicators are very similar. And obviously that sort of convergence, that standardization, if you like, although it wasn't actually done purposefully, led then to the greater ability to compare and to benchmark. And I think there's a much greater awareness now when countries actually embark on this journey to generate both domains and indicators which are comparable, especially for smaller states. I mean, countries such as Malta or Slovenia or Ireland, where you need to compare externally in order to actually understand your performance, because internal comparison would be quite limited, if you'd like. And as a result, I think we've sort of created this, also this community of shared practice, which is an informal process. So there's nothing formal about it, nothing official, but nonetheless, it then inculcates, then infiltrates the more formal political corridors of where we work, and hopefully then that will generate greater awareness of the ability of HSPA to actually influence policy in that sense.
Thank you. And I think as part of your work with the HSPA group, you've also looked at alternative methodological approaches to think about how countries may be different. So we work together on a vignette approach, for example, for patient access.
So patient vignettes was, for example, one such tool that we came up with in terms of actually gathering, not just gathering the information, but actually then comparing experiences across different regions, different countries. So using a common methodology to actually collect data across different countries.
Thank you. So that's quite interesting and a certain way of moving forward. Irene, you have been working on comparative studies on HSPA for quite a while. So what are your key takeaways on this?
So I think cross-country comparisons have great potential. They're a unique opportunity to look at how various differences in health system design or reform can potentially lead to different outcomes and are, if done right, I think a huge opportunity to learn from one another. But I think to be done well, there's a few things that, and I think we're moving in that direction, that it's important to consider. So one is that we need to be very kind of open and transparent and inclusive. If we're going to learn from different countries, we need to really bring together the different people who know about the countries. We need to know about differences in health policies, reform, health system design, practice, data collection, to be able, to truly understand, are the measures that we're using comparable? Are the approaches that we're using appropriate? Are the conclusions that we're drawing, do they make sense, in the current context? And I mean, a lot of the efforts that we're describing are these collaborative processes. They don't happen in one institution by one group of researchers who tries to draw conclusions about all of the countries. I think that's crucial to drawing the right conclusions. I also believe that we're moving to new methods and new approaches to cross-country comparisons that allow us to draw more nuance and more understanding about the differences in health systems that could be important to learn from. So for example, the vignette approach, there's many EU projects and some collaboratives that I've been involved in as well, where we look at the same type of patient and try to look at how they move through systems and the different care that they use, and really kind of trying to focus on a lot of the advances that have been made in data collection and data linkage within countries, to look then across countries and understand how does the same patient experience care through different systems, and where are different models of care happening, and where are there potential differences in the outcomes that these patients have that are important for us to identify areas to learn more from. And so I think this is a really promising area with a lot that's happening and COVID fueled a lot of this too, with more data sharing and more willingness, I think, to look at this across countries. So hopefully we'll see more of this work and be able to learn more from the different models that have been adopted in different countries, the different reforms that have occurred in different countries, to be able to draw conclusions about whether those can work in different settings.
Resilience. Resilience is one of the words that we have been using more in the last years. And it's important, I mean, that we can measure how prepared we are, and that at the same time we prepare to avoid or to be able to respond in future shocks. How we can use health system performance assessment that we have already established, that is not a tool, but a set of potential tools to measure this resilience. Marina.
So health system resilience is a concept that became acutely relevant to HSPA during the COVID, but actually work on measuring resilience and relating it to health systems performance started quite a bit earlier, a few years earlier. And our colleagues, Martin McKee and Steve Thomas, have been doing work on health systems resilience since before even the financial crisis. And then the European Commission did the report early on. And then the European Commission's HSPA group started also on the resilience report before the pandemic, and also worked on it during the pandemic. And then also we saw that resilience is embedded within the EU country health profiles. It was there from the very beginning, from 2017. But the potential breadth of the concept, and which we see in all these different works, actually presents a challenge for measurement, because resilience to economic shock can manifest in one set of strategies, whereas resilience to, for example, AMR resistance or population aging could potentially manifest in completely different set of ways or strategies. So in our ongoing project on the resilience testing, commissioned by the European Commission, and that we are working, the Observatory is working on it together with OECD, we use the HSPA framework to identify health system weaknesses that come in light in a specific shock. So HSPA framework serves for us as a map to see where disruptions are that are caused by a shock, and then we can try to attribute them to specific health system functions and identify areas where any actions can be done and resilience can be strengthened.
Thank you. Kenneth, you have responsibilities at national level, and at the same time you are the co-chair of the group of the Commission. How can really the countries use this tool to measure resilience, to improve the resilience, to do something to avoid that we suffer what we have been suffering in the last years?
Yes, well, as Marina said, I mean, resilience is not a new topic. It's been on the agenda, and especially even within Europe, quite a number of years. Obviously, it came to a head because of COVID. But also, as an expert group, we actually produced our resilience report just before COVID. It was almost in anticipation of what was yet to hit us. And I think Marina highlighted this also. We found that it's very difficult. The first difficulty we had was actually defining resilience, presenting a common definition that all countries can actually attribute to. And that's something that each country, each experience, presented definition, a different way of looking at resilience. And obviously you need clear definitions to be able to measure it. So that was the first challenge, so to say. And also then we went on to actually identifying proper assessment or measurement tools to be able to measure resilience as part of the HSPA process. Again, HSPA, resilience was not always part of the HSPA process. In fact, if you look at the models, the frameworks of countries before COVID, you very rarely see resilience written as a specific domain or dimension. Whereas now, post-COVID, quite a few countries have now either revising the frameworks, so Belgium, for example, or Ireland have actually incorporated resilience as a specific domain or dimension, and not because it stands alone, but because of its importance. Important in terms of measurement, also all the different measures that then link up to all the others, so equity and accessibility, etc. So as a concept, it's extremely important, but now we need to really operationalize what resilience really means for us. And I think few governments have yet managed to do that. And hopefully HSPA will allow governments to be able to incorporate resilience within their planning framework. Because at the end of the day, that's what it's about. It's planning for these shocks, for the unexpected, so to say. So that's important.
Thank you. Reinhard, any final word on that?
Yes, I don't want to spoil the party and that everybody thinks resilience is so important. But I mean, for me, it's not a new dimension, but because it depends on the starting point of a system. I mean, if you have a good system, you hope it's resilient in terms of crisis so that the results on accessibility, quality, contribution to population health, responsiveness remain the same, while a system which is not performing well could either go down the drain even more, or you hope that out of the crisis it's learning. So in a way, I'm a fan of this longitudinal analysis, and I think the longitudinal analysis from before a shock or a crisis to afterwards tells you more about resilience than trying to measure resilience by itself.
So what we need is to have data in a longitudinal basis, so always and not just do a study when we want to prove something. This is important.
I think that's a very nice summary, Isabel, or a key message, I would say. We turn to our audience, or to a summary of what our audience has been saying, and to Nicole Maurer, colleague from the Observatory, who will give us a short summary of the Slido.
Yes, thank you, Demi. So there has been a very active discussion, a lot of questions coming in. I would like to point out two main themes. So the first one is the role of HSPA and of measuring resilience for climate resilience specifically. So how do we make sure that climate is considered in health policy making? And are there any indicators for green healthcare systems considered in HSPA frameworks? In addition to that, are there any promising measures of resilience that we can operationalize right now? So what are the first findings from simulations that are being conducted? And the second one is the role of HSPA in policy making. So on the one hand, how do we mitigate the risks that policymakers can make political decisions that are based on false conclusions that are maybe drawn from HSPA? And how effective can HSPA really be at EU level given the limited competencies of the EU and on health systems? Yes, and then we have a number of clarification questions, but maybe we'll keep those.
I think we can put our lovely panelists on availability for the clarifications afterwards. I think both questions really reflect what we've been discussing, and I mean the second question in particular is also the title of the session in a way, right? So because we want to figure out how we can use HSPA for policy making in a way that is constructive, and that means sometimes that perhaps the policymakers will think that this means that it shouldn't be public. We heard that. It also contradicts the fact that the framework, for example, might be conceived as an accountability tool. So I would like to move us to the perhaps closing round of insights from our panelists, having heard the inputs from the audience, with your key, most important takeaways for policymakers to better embed HSPA in policy decision makers. So not only addressing policymakers, but also for our audience, how can we make HSPA progress it in a way that policymakers can use it to their best of their ability. And maybe we start with you, Irene.
Yeah, sure. So I have 3 closing points, and I'm going to try to bring in some of the questions in those. The first is I think we need to think of HSPA. I think sometimes we think of it as too simple of a process, and as we've seen, it can be used for different objectives. It can be done differently across countries. It can be done differently within countries, and it's important to think about what we're using HSPA to inform when we design it and try to use it and draw conclusions from it. So I think the question from the audience about climate is an interesting one. That's obviously a pressing challenge that all health systems are facing, and I do think there's a role where we can use the framework or HSPA to think about this. And I mean, one is just how climate affects health systems, right? You can think of there's going to be different shocks in different parts of the world that are going to look very differently within countries, across countries, that are going to create different challenges for the health system. It could be that they create challenges on the outcome ends by some environmental shock causing, a surge of a particular, increase in the incidence of some pathogen or some disruption to care. It could be that you see it on the functions end, that it disrupts service delivery, or it disrupts financing because you need emergency planning. So thinking about the ways in which these shocks can influence the outcomes and the way the structures are set up is one way to try to prepare for thinking about what happens. And of course that will look different in a country where climate-related shocks are fires and in a country where it's hurricanes, and planning for that will look different. But that's not the only way climate change affects health systems. There's also what health systems are doing to become greener, and that's a different way of thinking about the framework. And then again, going back to the functions and thinking about what are we doing here? What's the carbon footprint? Like, how are health systems contributing to climate change, and how do we change that? And that's a different use of the framework, but also I think one where we can think through all of the components of the health system and try to think one by one, where can we do something to address this? So there's ways I think where these frameworks offer a tool, because they offer you a way to look at the different components of the health system and try to think one by one with a particular challenge, be it climate change, be it economic shocks, be it COVID, where are the sensitivities of the health system, and then how do they link together, and how do we prepare for them? So the second thing I think, which again is related to this, is we need to move away from, I think, and move towards some of the new capabilities in terms of how we use data. And as we've seen from a lot of examples, we need to do more longitudinal analysis. We need to use more innovative methods to take advantage of the data that exists in Europe across countries, individual patient level linked data. So there was a question about what the EU can do to help HSPA. I think the European data space is a great initiative that will help HSPA. We heard yesterday about data linkage within countries, federated models to do analyses. These are all things that can take HSPA to a next level, and I think those are, that's how the EU can really support progress in this area. And I think the third thing is, as we've heard again and again, good health system performance assessment requires inclusiveness, transparency from all stakeholders, and I think that's how it can be used best for policy, by bringing in practitioners, policymakers, patients, people who use the system to get the perspectives of where they think are the sensitivities and interpretation of indicators, and really being kind of sensitive to what we're looking at, and making sure that we involve all stakeholders in thinking about what these indicators mean and how we address them.
Thank you, Irene. All very important points. Kenneth, do you agree? Have some additional ones? Definitely.
No, certainly, definitely. Yes, but I think I take perhaps from a different perspective, not necessarily from the scientific or technical, but again from the political. Mm-hmm. And again, HSPA is now, we can't say HSPA is a new thing. It's been around for quite a number of years now. And I think the next step is really to legislate or to embed HSPA within some kind of governance framework at the national level. At European level, that will probably be more difficult to achieve, but certainly those governments that have actually incorporated HSPA either legally within the legislation or at least administratively have actually reaped most benefit from it. So I think that's really the next step that needs to be carried out, and certainly it could be extremely useful for health planning purposes and for the budget. So to insert HSPA within the budgetary cycles, for example, or the health planning cycles of different countries. Obviously, the purpose of that is to inform the plans, inform the policies, inform the budgetary process. So that's very important. And then I think finally, certainly, it's the issue of open communication and transparency. I think the HSPA model does not work if you don't have a transparent process, both in terms of the actual methodology, but even more so in terms of the issue of the results and the discussion of the potential impact of HSPA on policy. So if we have that open, transparent discussion, that will, again, be extremely important. Not all countries have managed yet to do that, because it takes a certain level of maturity, even at the political level. But certainly that's certainly the road that needs to be taken in the future.
I have to intervene here. You know how difficult it is to legislate at European Union level.
Yes, yes.
But there are always other measures, soft measures. Like there is the European semester and the support to the reform policies, the financial support to the health system. So there is always a way, not necessarily the legislation, but to intervene at EU level.
Thank you, Isabel. I think also at the national level, as Kenneth mentioned, it's not always easy, and maybe it's not desirable from the political side of things, but it's definitely desirable from the technical side of things, where we talk about that. Certainly. Marina, we come to you.
Yes, just very briefly. So HSPA exercises should not be seen as a collection of indicators showing some good and bad things that are happening within the health system and just end there. And for it to be meaningful, we need to see HSPA as a starting point and embedded into policy making, if that's possible, as Kenneth was saying. And some countries do that already, but also as a minimum, in the next step would be asking why we see certain results, and then, so what? Do we even care about what's happening? And then, if there are implications, then who can act on this, just to make policymakers accountable?
Thank you. Reinhard, we come to you for the end.
Yeah, I mean, the question of the climate also reminds me when we started the process in Germany, the question is, where are the borders of the health system? So what is influenceable by health policy makers? For example, if people live in urban and rural areas, you would say, okay, these are different starting points, but it's outside the power of policy makers to move people from rural areas to urban areas and vice versa. So we say we need to adjust or look whether health policy is similar in urban and rural areas. So these are determinants which are outside our power. On the other hand, if you concentrate only on the health care component, you would say, okay, then people who smoke more have a higher risk of lung cancer. And if you only look at the lung cancer treatment, you would say, wait a minute, why isn't the health system also looking at the prevention? And so this is what I showed yesterday with the preventable and the treatable amenable mortality. So we should take this in view. If we do that, then I think with things like climate, we are thinking, okay, is climate, and I think we used to say climate is more something like urban-rural, so outside our sphere of influence. The more we say, wait a minute, climate change is actually something preventable, then we have to take it into account and say we put this into our into our health system performance assessment as something where we can prevent mortality, other ill health to happen. And if we do that, then I think we also address the question what the EU can do, because the more we solve this upstream, downstream thing, then with the determinants of health, including climate, but smoking, nutrition, and so on, we do have a mandate of the European Union. If we only look at the healthcare system, at how many intensive care units we are having, and whether they avoid mortality, then we are in the national country sphere. So we need both, but that I think needs a new reflection on the boundaries of the health system and the boundaries of health system performance assessment.
Thank you. And perhaps a final statement about how we make this clearly for policy, how we embed HSPA for policy tangibly. How do we actually do this?
Well, I think the first and foremost thing, and I don't want to repeat myself too much, is that policymakers realize that their own system is not optimal, and that sometimes looking across to other countries is actually useful, and but you need to have this embedded in your thinking that there could be something. It's not, the grass is not only looking greener on the other side, maybe it's really greener, and you could ask your neighbor, why is your grass greener? So I mean, what are you doing differently than I do?
Thank you. And I think this brings us very well to this the notion of a conference. It's a European conference of learning from best practice from one another. Links really well. Isabel.
Yeah, I think so. And as a reminder that the evaluation of the health systems is very important. But at the end, we are in health in our policies and health impact assessment of other policies. So we are back to the beginning and closing the circle. So thank you very much to all of us. We have now the parallel sessions, and we wish you a fruitful morning and day and conference in general. Thank you very much.
And we have an interesting late breakers.